Okay, Assalamu alaikum everyone. My name is Noor Waseem, and today we will be doing the session Metabolism and Diabetes. If you remember, even for MOL 1, I did the last session, which was vitamins 1 and 2, and lucky enough to do the last session for MOL 2 as well. So I hope it's going to be an interesting session. And trust me, this one is the easiest lecture, at least for me, and I've made this PPT in a way so that it becomes as easier for you guys as well as it was for me. And yes, let's begin. If you guys have any questions, feel free to text me in the chat box. You guys can text on Noor's iPad or like even on my other account. And yeah, so let's begin. So we will be talking about the differences, the mechanisms of type 1 and type 2 diabetes. We will be exploring the metabolic abnormalities present in both type 1 and type 2, the treatment approaches for type 1 and type 2 diabetes, and then we will also be identifying the complications linked to both of them and the lifestyle choices when it comes to type 2 diabetes. Okay, now what is diabetes mellitus? Why do we add mellitus with diabetes, and why do we not just call it diabetes alone? Well, there's an interesting story behind this. Like, I guess like many years back, like a couple of years, not couple, like so many years back, um, the way how diabetes was diagnosed was really weird. Like they did not really have any kind of testing. They did not have like the sugar testing machine. So they used to taste urine. And even though it sounds weird, but like in those times, this was the only way to diagnose diabetes. So if the urine was like really, really, really sweet, the doctors or like whoever the lab technicians are, they would like diagnose that the patient has diabetes. So mellitus basically means honey or sweet. So this is how the name mellitus is with diabetes. It is called diabetes mellitus. Now, what is diabetes? It is a cluster of syndromes characterized by elevated blood glucose levels due to inadequate insulin production. Now, there are two types of diabetes, diabetes 1 and diabetes 2. Now, diabetes type 1, it is known as insulin dependent diabetes, and type 2, it is known as non insulin dependent diabetes mellitus. Why? We'll just do it in a while. Type 1 diabetes, it results from absolute deficiency in insulin production. So what happens in type 1 diabetes? You have your pancreas. You know, our pancreas has islets of Langerhans, and those islets of Langerhans, they have the alpha cells, beta cells, delta cells. The beta cells are basically involved in the production of insulin. Now, what sometimes in type 1 diabetes, our body, it undergoes an autoimmune reaction. Autoimmune reaction means the reaction of the body within itself, like it attacks the body's immune system or the body system, the body itself attacks. So in type 1 diabetes, an autoimmune reaction of the body destroys the beta cells of the pancreas, which means now because the beta cells are destroyed, insulin is not being produced. Okay, so there is like complete deficiency of insulin. So what happens when a person eats glucose or has glucose in his diet? There is going to be like hyperglycemia because the glucose is getting accumulated in the body, and now because the beta cells are destroyed, there is no insulin, so there nothing is going to work on glucose. So in this case, the patient will be having hyperglycemia, high amounts of glucose in the body. So the best treatment for this is to give insulin, because the beta cells are not producing insulin, there's hyperglycemia, and the only way you can treat the patient is that you give insulin. Now, talking about type 2 diabetes, it is characterized by a relative deficiency in insulin or insulin resistance. Now, what does this mean? Relative deficiency in insulin means that in type 2 diabetes, there there are beta cells, but they're not producing insulin the way they're supposed to be producing, okay? Or insulin resistance, insulin is being produced in normal amounts, but it is not being acted on the cells, right? There's an issue with receptors, there's an issue with the cells. In that situation, it is called insulin resistance because your body is now resistant to insulin. So type 2 diabetes, you have insulin, but your cells are not reacting to the insulin, or glucose is not being reacted by the insulin. Or you have good amount, your pancreas is good, it does not produce enough amount of insulin. Okay, so it is either deficiency in insulin or it's insulin resistance. So the best solution for type 2 diabetes is lifestyle modifications, and we will be doing it towards the end. So, how do you diagnose diabetes? Now, there are three main tests to diagnose diabetes. One is fasting plasma glucose, the other one is HbA1c, and the other one is OGTT, which is oral glucose tolerance test. Now, fasting plasma glucose, it's basically a kind of test. I'm sure you guys must have seen the glucose measurement machines in the hospital, and even we also have them in the pro department right now. So if the fasting plasma glucose is more than 126, higher is more than 126 on two separate occasions, it means that the person is diabetic. Okay, HbA1c level, it is a kind of blood test which if it's more than 6.5% on two separate occasions, the person is diabetic. Or glucose tolerance test, in this kind of test, the doctor or the nurse would give you around 75 grams of glucose, and 2 hours after you had your glucose intake, your blood sugar level will be tested. And if it's more than 200 or higher, it means that the patient is diabetic. Okay, so remember these three tests. These are like really important. Like you can get an SEQ to ask you to confirm to confirm the diagnosis of type 2 diabetes. Okay, so also urinalysis is a quick screening test. Urinalysis is basically the test of your urine, and usually glucose should not appear in urine, but if it appears in urine, it means something is wrong. Okay, in most of the cases, the patient has diabetes. And it's only when the blood glucose level it's between 160 to 180 or slightly higher, the glucose starts appearing in urine. Okay, so you can also do urinalysis to find out if the patient is diabetic or not, but like these three are like the most convenient way to measure glucose levels. Okay, HbA1c. Now, we spoke about the HbA1c here to diagnose diabetes, but what exactly is HbA1c? Now, HbA1c, it's basically glycated or glycosylated hemoglobin. What does this mean? You have the hemoglobin molecule, okay? Now, a part of hemoglobin molecule will have glucose attached to it, okay? That is why it's called glycated or glycosylated hemoglobin. Now, this is proportional to the average blood sugar level over the past 3 months. Now, why past 3 months? You know how red blood cells have hemoglobin? And I just said that hemoglobin has glucose attached to it in like 1% of the hemoglobin. And we know that the lifespan of red blood cells is 3 months. Now, because the lifespan of red blood cells is 3 months and the hemoglobin living within the red blood cells will also be there over a span of 3 months, including the glucose that is attached to the hemoglobin. Now, that hemoglobin will be surviving in the red blood cells for 3 months, and the glucose attached to the hemoglobin will also be surviving for 3 months until it dies. So that is why it gives an average of the past 3 months. So it's related to the lifespan of RBCs. Okay, it's a very good indicator of how effectively diabetes treatment has managed to stabilize blood sugar during that period. Now, symptoms of diabetes, like you guys can go over it. It's frequent urination, excessive thirst, weight loss, increased hunger, fatigue, blurry vision, a slow healing wounds, tingling, numbness in the feet or toes. Now, talking about type 1 diabetes, just to recall, I just said that type 1 diabetes is the kind of diabetes where your beta cells of the pancreas are destroyed, and beta cells are the ones that are responsible for producing insulin. Now, because the beta cells are destroyed, it means you cannot produce insulin. Okay, so again, like just the symptoms that we spoke about. Okay, now this is like just an overview of what I said. Like it's an autoimmune destruction of the pancreatic beta cells, resulting in complete lack of insulin production. How does this reaction actually happen? So basically, we have T lymphocytes which infiltrate the islets of Langerhans, and that causes insulitis, which is basically inflammation of the islets of Langerhans, and that slowly and gradually depletes or it destroys the beta cells. So no insulin produced. As a result, the treatment is insulin therapy. Okay. Now that we have spoken about the autoimmune reaction, now there should be something that is triggering this kind of autoimmune reaction, right? So what actually happens in type 1 diabetes? Now look at the step one, it basically says that there is exposure to virus or toxin. Now, the body is exposed to virus or toxin, and that starts beta cell destruction in individuals with genetic predisposition. So first step is you need to have immunological reaction, that is an exposure to virus or toxin, and that when it is exposed to the islets of Langerhans, that will slowly and gradually get into the beta cells and start planning to destroy the beta cells, and hence no insulin produce. So next step is once they get in, there is slow beta cell destruction. So over a period of years, beta cells are destroyed, resulting in decreased production of insulin. Now this line is for insulin. Now you see how the insulin is being decreased, but at this point insulin like beta cells are completely destroyed, which means insulin is like no longer being produced. And it's like if you think of it in a way that it actually takes so many years for all of your beta cells to be destroyed, and after about 90% of your beta cells are destroyed, then it is then when symptoms start appearing. So, like it said, when the insulin secretory capacity falls below a threshold, the symptoms of type 1 diabetes suddenly appears. So it takes like a good number of years. Like you can see the years of autoimmune destruction of beta cells, it took around like 9 or 10 years to destroy the beta cells completely. And it is then when the person realizes, oh, I'm having symptoms, something is wrong with me. So it takes like it's like a good amount of time to diagnose that the patient has type 1 diabetes. Okay. So beta cell destruction, what I just spoke about, it requires a stimulus from the environment, such as a viral infection, the one that we spoke about here, and a genetic determinant that allows the beta cells to be recognized as non-self. Now, in monozygotic or identical twins, if one sibling develops type 1 diabetes, the other twin has like 30 to 50% chances of developing it. And in type 2 diabetes, the genetic influence is stronger, like it runs in the family, which is like type 2 diabetes is very common. It's much more common than type 1 diabetes. Okay, what is a clinical presentation now? If you have a patient, how would he present with, or what does he like say? You, oh, these are the symptoms that I have. On which basis you will start diagnosing? Oh, this is type 1 diabetes. Okay, so okay, onset. Remember, the onset of type 1 diabetes is basically the pediatric population, childhood or puberty. The presentation is like the classical presentation, which is 3 Ps: polyuria, polydipsia, and polyphagia. Polyuria is frequent urination, polydipsia is excessive thirst, and polyphagia is excessive hunger. So remember, type 1 diabetes, 3 Ps: polyuria, polydipsia, polyphagia. This is like really important. You can get this in an SAQ. Also, the patient will be having fatigue, weight loss, and weakness. Diagnosis, like we just said above, like if the fasting blood glucose is more than 126, the person is diagnosed with type 1 diabetes, and also if HbA1c is more than 6.5, it's also that a person is diagnosed with diabetes. Okay, now symptoms explained for type 1 diabetes. Now, once the blood level sugar is more than 180, the ability of the renal sodium-dependent glucose transporter to reabsorb glucose is impaired. Remember, I said that normally urine should not be having glucose. Yes, it does have glucose, like just a very minute amount. But if the blood sugar level exceeds 180, glucose will start appearing in urine. Now, because glucose is an osmotic molecule, it pulls along water with it, right? So it's observably glucose spilling in the urine. So one, like I said, urinalysis can also be a way of diagnosing diabetes. And if you do the urinalysis and you see high amounts of glucose, you can predict that, or you can come to a differential diagnosis of type 1 diabetes. Now, because glucose is an osmotic molecule and it pulls along water, it causes the typical polyuria, which basically means excessive urination, and polydipsia. Now, because you're urinating more, so you need to replace that water. So you will be more thirsty. So you will be drinking more water. Okay, so polyuria is due to osmotic imbalance from elevated glucose levels in the urine. Now, in untreated type 1 diabetes, weight loss occurs because the liver requires gluconeogenic precursors. Okay, now why is there weight loss? The reason why there is weight loss is because now the beta cells are destroyed, okay? And insulin is not being produced. What about the cells? Now, the cells, they need glucose. Even though the body has glucose, there is so much glucose. There's hyperglycemia in type 1 diabetes. Because the insulin is not there, and insulin is responsible for the uptake of glucose into the cells, okay? Only when insulin is there, glucose will enter the cells and the cells will start generating ATP and energy and whatnot for the proper functioning. And the body will feel energized. Now, because the insulin is not there due to beta cell destruction, there is no uptake of glucose into the body cells. And as a result, the person will start losing weight. Why will he start losing weight? Now, the body's not getting energy. So body will start finding out other ways to find energy and to make sure the body is energized and the cells starts working. So one way of finding that energy is through gluconeogenesis, which is basically the formation of fatty acids through non-carbohydrate precursors, and that generates energy. Like it's an alternate mechanism to the glucose uptake. Now, because glucose is not there and you're not having energy, you can use other processes which involves like muscle wasting, and you start losing weight because of that. Okay, so it's more like the body saying, okay, I have hyperglycemia, but I do not have insulin. Now, because I do not have insulin, how will I take in glucose in the cells and generate energy? So what happens? The body has other mechanisms, like I just mentioned, gluconeogenesis, for example, the formation of fatty acids to generate energy through non-carbohydrate precursors, and then it starts losing energy, and the person also loses a lot of weight because of that. Okay. Okay. Now, how does insulin affect carbohydrate metabolism? Now, let's say that you it's a normal person. Okay, now he's having enough insulin being produced in the body. So it's like just simple, like if you guys memorize it, I think it's like the best option. And it's like self-explanatory. Okay, so insulin, it boosts the glucose absorption by promoting the presence of glucose transporters on muscles and fat cell membranes. Okay, so like I said, it helps in glucose absorption, it helps in uptake of glucose. And then insulin limits or lowers the glucose production by inhibiting glycogenolysis and gluconeogenesis in the liver. And insulin, it also like limits the glucose production and it inhibits glycogenolysis. Glycogenolysis is basically glycogen being broken down into glucose. So that is being inhibited here by insulin. And also gluconeogenesis, like I said, the formation of free fatty acids through non-carbohydrate precursors. And insulin promotes or it increases glycogen formation in both liver and muscle cells. Okay, so you know how glucose is converted to glycogen and then it's stored in the liver and muscles. So one of the function is basically to convert glucose to glycogen. Okay, like this is the normal function of insulin on carbohydrates. Now, how does insulin affect lipid metabolism? Now, these two are important. So, insulin, it inactivates hormone-sensitive lipase activity, reducing lipid breakdown in fat tissue, which decreases lipolysis. Now, think of it this way. Think that insulin is like a switch that turns off a process called lipolysis. Okay, and lipolysis is when fats are being broken down into fat tissue. So when insulin is around, what it does, it stops the breaking down of fats, means less fat is released from fat tissue into the bloodstream. So the overall result is that there's less fat breakdown, right? So it's keeping the fat, it's trying to keep the fat, it's making sure the fat is not being broken down. And the next point talks about lipoprotein lipase activation. Remember, insulin inactivates hormone sensitive lipase, and insulin activates lipoprotein lipase activation. So, insulin activates lipoprotein lipase, like I said, and that's a process that helps insulin store fat. Now, it's like turning on a machine called lipoprotein lipase. Now, this machine, it's going to break down chylomicrons, okay? You know how we have chylomicrons, and chylomicrons usually have triglycerides inside, plus there's a few cholesterol molecules. So when like I said, think of it as a machine. This machine, which helps break down chylomicrons, it carries fats, releasing fatty acids. Now, these fatty acids then goes into the fat cells, which is the adipocytes, and they join with glycerol molecules to form triglycerides. Okay, when they form with glycerol molecules to form triglycerides, it is a kind of fat, and the overall result is that more fat is being stored in the cell, right? So the first point actually meant that the overall result is less fat breakdown, and the second point mentions about more fat being stored in the fat cell. So it's a way of keeping the fat and making sure that there is no breakdown, and also making sure through lipoprotein lipase that there is more fat stored in the fat cells. Okay. Now, talking about metabolic changes in type 1 diabetes. Now, insulin deficiency, it impacts the metabolism in liver, muscles, and adipose tissues. Hallmarks of untreated type 1 diabetes is hyperglycemia and ketoacidosis. So, like I just mentioned it again and again, when you do not have insulin, is there any question? Okay, when you do not have insulin in your body, what happens is that glucose will be accumulating, right? So that's going to cause hyperglycemia. Pretty straightforward. So just to read it, hyperglycemia arises from increased gluconeogenesis and reduced glucose uptake in muscle and adipose tissue, which relies on insulin-sensitive GLUT4 transporters. Talking about ketoacidosis. So ketoacidosis is basically a process which happens when your body does not have enough insulin, like for example, type 1 diabetes, like I just mentioned. Now, when your body does not have enough insulin to use glucose for energy, it starts breaking down fats for energy, or like fats for fuel. Okay, it needs energy from somewhere else if it's not getting from glucose. So in ketoacidosis, what happens? It uses a process of breaking down fats. This creates ketones, and ketones are like, they start building up, and they're acids which are really not good for the blood. So it can happen to people with diabetes when their blood sugar level gets too high for too long. It's serious, and it really needs medical attention. So ketoacidosis is one of the hallmarks of type 1 diabetes. You might see ketoacidosis in type 1, but rarely in type 2. So, like I just mentioned, ketosis, it results from increased fatty acid mobilization, leading to production of 3-hydroxybutyrate and acetoacetate, and these two are ketones. Okay, and diabetic ketoacidosis affects 25 to 40% of newly diagnosed type 1 diabetes patients and can reoccur during illness or non-compliance with therapy. Okay, okay, so this point, which basically mentions about excess fatty acids in the liver that cannot be processed through oxidations or ketogenesis, are converted to triacylglycerol and are released as VLDL. In diabetics, low lipoprotein lipase, which is basically an enzyme that breaks down triglycerides in chylomicrons to release fatty acids, activity in adipose tissue leads to high plasma chylomicrons and VLDL, causing hypertriacylglycerolemia. So remember that in type 1 diabetes, one thing that you're also going to see is hypertriacylglycerolemia. I know it was kind of heavy, but let me explain you. Now, I mentioned about excess fatty acids, right? So when there are too many fatty acids that enter the liver, what happens? The liver cannot dispose all of them, right? So they're breaking them down for energy or ketogenesis, but the liver cannot get rid of all of them. So what happens? They are converted to triacylglycerol. Now, the liver converts these excessive fatty acids into triacylglycerol, which is a type of fat. And talking about packaging and secretion VLDL. So what happens when the liver converts these excess fatty acids into triglycerol? It packages the triglycerol into very low density lipoproteins, which is VLDL, and then it secretes them into the bloodstream. Now, talking about low lipoprotein lipase, remember how I mentioned here that insulin, it activates lipoprotein lipase, right? This is the normal function of insulin. And in type 1 diabetes, when there is no insulin, it means that there is low lipoprotein lipase activity, like I just mentioned. And when there is low lipoprotein lipase activity in people with diabetes, now And because it's an enzyme in adipose tissue that breaks down lipoproteins, right? Now that is low. So that elevates the plasma chylomicrons and VLDL. Again, because of low LPL activity, chylomicrons and VLDL, they accumulate in the bloodstream. That causes hypertriacylglycerolemia, which basically it's an accumulation which leads to high level of triacylglycerol in the blood, and this condition is known as hypertriacylglycerolemia. Okay, I hope all of this is clear, and this is just like a summary of what I just said above. You guys can go over it, but because I was like just comparing this picture with the rest, I feel that I've mentioned everything from the slides, from Dr. Hannah's slides. Yeah, it was Dr. Hannah's lecture. So, is there any question up until now? Okay, so I assume there is no question. So let's go to the next step, which is basically, okay, thank you, Kusai. Now, talking about the treatment of type 1 diabetes, like I just mentioned, beta cells destroyed, no insulin being produced, hyperglycemia means high glucose in the blood. So the best solution that you can give the patient is insulin therapy. So you either give exogenous insulin, which is injected subcutaneously, or insulin pumps with adjustable flow rates, which are kind of these. Okay, so each time they detect that there is a low amount of insulin, they produce more. These pumps, they have insulin, and they can like produce more. They can pump insulin into the body so that it can help decrease the effects of hyperglycemia. Okay, so now, excessive insulin leading to hypoglycemia is a frequent issue with insulin treatment. Now, you're giving the patient insulin. He has hyperglycemia. So, at times when you give an excessive insulin to a patient who already has hyperglycemia, that can result in hypoglycemia because that too much insulin has acted on too much of glucose, and now the result is hypoglycemia. So, normally, in normal individuals, hypoglycemia prompts the body to release glucagon and epinephrine, okay, which stimulates the liver to produce glucose. Now, however, in patients who have type 1 diabetes, there is a deficiency in glucagon secretion, and there is a deficiency in the release of epinephrine due to a neuropathy. Neuropathy means like damage to nerves. Okay, so what happens in these long-standing diabetes? These patients are very prone to hypoglycemia now because, like I mentioned, that glucagon and epinephrine is also not being produced in patients with type 1 diabetes. What happens? The liver cannot produce more glucose. So now, because the liver cannot produce more glucose and the patient is already hypoglycemic, he will have more effects of hypoglycemic. Main reason that epinephrine and glucagon are not being produced. Okay. Okay, so we're done with type 1 diabetes. Now on to type 2 diabetes, which is very interesting. Like I just mentioned, it's much more common than type 1 diabetes, and also it runs in the family. So let's see exactly what happens in type 2 diabetes. Now, type 2 diabetes, it is a metabolic disorder in which there is insulin resistance and impaired insulin secretion. Now, let's talk about impaired insulin secretion. Now, you do have pancreas, okay? Now, that has beta cells, okay? Your pancreas is okay, but due to some problem in the beta cells, they're not able to produce the normal insulin that they're supposed to produce. Okay, so that is impaired insulin secretion. Now, insulin resistance is your body is producing insulin, but it's not being acted upon on the receptors or on the cells, right? So there is a defect in the receptors and cells. So again, there's going to be a problem in the uptake of glucose, and like this is why it's called insulin resistance, because your body is resistant to insulin. So again, they're just talking about pancreas not producing enough insulin that can lead to high glucose. Okay, of course, when there is no enough glucose being produced, when there is no enough insulin being produced, there can be hyperglycemia, and that increases glucose, of course. And there's a problem in insulin receptors on the cell. So what happens, even though insulin is being produced, it's not being acted upon on the cell. So there's going to be increased insulin resistance, and that's going to cause hyperglycemia. It is detected by routine screening testing. Patients will come with polyuria and polydipsia. Again, increased urination. Polydipsia means increased thirst. Now, patients with type 2 diabetes have a combination of insulin resistance and dysfunctional beta cells. Like I just mentioned, does not require insulin to sustain life. You do not need to give the patient insulin in this case. Remember, in type 1 diabetes, I told the best treatment is to give the patient insulin therapy. But in type 2 diabetes, the best method is giving either anti-diabetic drugs, or like the first line method or treatment is to ask the patient to have some lifestyle modifications like exercising, dietary modifications, which are really helpful in this case. And yeah, like remember, in type 2 diabetes, the metabolic alterations, like for example, remember I told type 1 diabetes a hallmark is ketoacidosis. So you won't really see ketoacidosis in type 2 diabetes because there is insulin secretion in type 2 diabetes. Okay, type 1 diabetes, there was no insulin secretion. So as a result, in order to produce fuel through other methods, it underwent the process of ketoacidosis, which was the production of ketones, and those ketones were acidic to the body, to the blood, and that process was called ketoacidosis. But here you do have insulin, so even like a little amount of insulin would somehow help the cells to function properly, or they might take little bit of glucose into the cells. So this is like the main difference, so don't forget this. Okay, now how do we diagnose type 2 diabetes? Already mentioned above, if fasting blood glucose is more than 126, it means patient has type 2 diabetes. A fasting blood glucose of 100 to 125 is an impaired of fasting blood glucose level, and it is also known as pre-diabetic. Pre-diabetic means about to turn into a diabetic patient if not taking proper treatment or proper actions or dietary modifications during that time, that can have a high risk of type 2 diabetes. Okay, but remember, more than 126, you diagnose diabetes. um, Remember how I said the type 1 diabetes, it has an immunological reaction, or it's also an autoimmune reaction. Remember, there was a graph and I mentioned how a virus attacks the beta cells of the pancreas. In type 2 diabetes, there is no involvement of viruses or autoimmune antibodies like how we had it in type 1. And the main mechanism is like obviously not completely understood, but yeah, it's genetic predisposition and also runs in the family. Um, Now, talking about these pictures, okay? So, if you look at this, now there are two factors that can result in hyperglycemia, okay? So, like, it's honestly just a repeat of what I said above. So, if there's insulin resistance in peripheral tissues, okay, as in your cells do not, there's a defect in the cells or in the receptors that they're not able to take insulin and have glucose in them, right? So this is one. And two is inadequate insulin secretion from beta cells, like I just mentioned. You have pancreas, there are beta cells, but like the amount of insulin that you're supposed to produce, you aren't producing that. Now, talking about obesity, now one of the main factors as to why type 2 diabetes is very prevalent is because of obesity. Of course, obesity means being overweight. Now, what does obesity do? Obesity, it changes secretions in the adipose tissue. Now that causes insulin resistance. Okay, now type 2 diabetes, it's mostly about insulin resistance. Um, Now talking about insulin resistance, it increases adipose lipolysis, which basically means lipolysis breakdown of fats or lipids into free fatty acids in order to generate energy, and it decreases fatty acid oxidation. Now, the result of these two is that there's increased free fatty acids in the body. And also, it increases hepatic gluconeogenesis. Like I said, gluconeogenesis is basically the production of free fatty acids from non carbohydrate precursor in order to generate energy. And it also decreases the glucose uptake by muscle and adipose tissue, which increases the blood glucose. glucose. So remember, in type 2 diabetes, we have increased free fatty acids and there is increased blood glucose. Now, coming back to insulin resistance again, just let me see if there's any question. Okay. So insulin resistance again, decreased ability of the target tissue such as liver, adipose, and muscle to respond properly to insulin. There is uncontrolled hepatic glucose production. There is decreased glucose uptake by muscle and adipose tissue. There is increased adipose lipolysis. Okay, and what are the risk factors of insulin resistance or having insulin resistance? It is old age, obesity, like I mentioned here, one of the main factors, and that results in insulin resistance. And being physically inactive means having no exercise, having no physical activity, so it's one of the risk factor, and also pregnancy, like around 3 to 5% of pregnant women develop gestational diabetes. There is another slide on gestational diabetes, and we'll talk about it. Now, insulin resistance and obesity. Okay, so like I said, one of the main reasons as to why people develop insulin resistance is because of obesity. Insulin resistance rises as body weight increases and it decreases as weight is lost. That is why, remember, I said the best solution for type 2 diabetes is dietary modifications or like lifestyle modifications, which includes exercise. Okay, so when the weight is lost, insulin resistance would decrease. Okay, so remember this way. Obesity leads to alterations in adipose tissue secretions, contributing to insulin resistance. Now, before I go to the next 2 points, just listen to me carefully. You know, when you're obese, your fat cells, they start releasing different substances. Now, some of these substances are interleukin 6, which is a pro-inflammatory cytokine that causes inflammation in your body. Now, this inflammation, it can make it harder for insulin to work properly. Okay, you're obese already, and there is insulin resistance, and now there is a substance called interleukin 6, which causes inflammation in your body. And this inflammation acts against the insulin and it makes insulin to work harder. It's harder for insulin to work properly. Now, this leads to a condition called insulin resistance. Okay. Now, at the same time, when someone is obese, it also reduces the amount of a certain hormone which is called adiponectin. Okay. Now, adiponectin is a hormone that our fat cells release, right? So it helps fight inflammation and make your body sensitive to insulin. Okay, adiponectin, it fights inflammation. Now, if there's inflammation, adiponectin will go fight inflammation. But in obese people, there is less amount of adiponectin. Okay, so it cannot fight inflammation. So when there is less adiponectin, what happens? Your body has even more troubling responding to insulin. So both of these, somehow the end result is like less response towards insulin. Okay, so these changes in the stuff that are released by your fat cells, for example, interleukin 6 and adiponectin, when you're obese, it makes it tough for your body to use insulin properly. Now, this can lead to health problems. Okay, so I hope this is clear. Is this point clear? Is there any question for those of you who are here? Okay, clear. Thank you. All right. Now, talking about the graph that's here, the main thing that you need to remember here is that in obese people and versus normal people, in obese people, for the same correction of blood sugar, you would require twice the amount of insulin than normal people, right? So if you see here, red here is for obese and blue here is the normal person. So higher insulin levels are required to control blood glucose in the insulin resistant obese individual right now, because he's obese and like I said, he produces inflammatory substances like IL-6 and also reduced secretions of adiponectin. So as a result, insulin is not working properly, right? So he would need a lot more insulin to bring about the same effect that a normal person would have, okay, through little insulin. Now, the blood glucose is kept within the same narrow range throughout the day in both normal weight and obese individuals. The blood glucose was kept normal in this experiment for both patients, but the major difference came in controlling the blood glucose through the amount of insulin. Like I said, obese people would need double the amount of insulin as compared to normal people. Okay. Now talking about progression of blood glucose and insulin levels in patients with type 2 diabetes. Now in type 2 diabetes, the pancreas initially retains beta cells capacity. Okay. Remember I mentioned that you do have pancreas, but it's not really producing the amount of insulin that is required by your body. But slowly and gradually, what happens? Your beta cells would become dysfunctional. Okay. Now, don't confuse this with type 1 diabetes. In type 2 diabetes, like in type 1 diabetes, it's like the first step is complete destruction. Here in type 2 diabetes, you will initially have beta cells, but they will like slowly and slowly and slowly diminish. So, however, with time, beta cells they become increasingly dysfunctional and they fail to secrete enough insulin to correct the prevailing hyperglycemia. Okay. So, just a recap of what I said: a patient has insulin resistance through the factors of genetics, obesity, sedentary lifestyle, aging. So insulin resistance, you have insulin in the body, but it's not acting on your cells. So because there's high amount of insulin, slowly and gradually there will be more and more insulin, you will have hyperinsulinemia, which is high amount of insulin in the blood. Now that impairs the glucose tolerance. Now when the glucose tolerance is impaired, there's decline of beta cell function. Now beta cell function is declining, that results in type 2 diabetes. So over the years, in patients with type 2 diabetes, there can be microvascular complications, which is retinopathy, which basically means the accumulation of glucose molecules in the blood vessels of your retina, neuropathy, which is damage to the nerves, and nephropathy, damage to the kidney. Talking about macrovascular complications, people with type 2 diabetes are more prone to cardiovascular diseases and stroke. Okay. And here, I believe I've already explained this concept. Like this is basically years of diabetes. So this is the graph for insulin secretion over the years, over 25 years. And this is the graph of glucose in the same person. Okay. Now it says obese individuals develop insulin, which may precede the development of diabetes by 10 years or more. Now, patients diagnosed with type 2 diabetes initially show insulin resistance. You see, initially the insulin is increasing, and glucose is also increasing. Like there is no effect of this high insulin on this glucose, so it means that there is insulin resistance. Subsequently, beta cells dysfunction occurs. There is declining insulin secretion and worsening hypoglycemia. Now you see how insulin secretion decreases because beta cell dysfunction is occurring over the period of time, but still hyperglycemia is increasing and increasing and increasing. So just remember that. Okay, again, it's just a summary of what I said above. Just remember, in type 2 diabetes, the insulin is being produced, but it's not being produced like how much the body would want it. So there's diminished effect of insulin on target tissue as a result of insulin resistance. Okay. Now, we just have like few more slides. Any questions until now? Okay, so no questions. Now, talking about the treatment of type 2 diabetes, the best treatment for type 2 diabetes is just memorize this: weight reduction, exercise, and dietary modification. Okay, now this would help correct the hyperglycemia in newly diagnosed patient. Okay, so when you encounter a patient with type 2 diabetes or he comes to your clinic and he's newly diagnosed, like the best suggestion you can give him to reduce your weight. Remember, when you reduce your weight, you decrease the effects of insulin resistance. So now the pancreas is also trying to work properly, and also the receptors might also start becoming functional in order to accept insulin and uptake glucose and decrease the effect of insulin resistance. Okay. The second one that you can give is anti-diabetic drugs. And in severe cases of type 2 diabetes, you give insulin therapy. Usually insulin therapy is very common and the best treatment for type 1 diabetes. But in type 2 diabetes, if you have severe cases, you give insulin therapy. Okay, so this is like the gold standard treatment. Anti-diabetic drugs, you guys can just like memorize the names. I will just quickly go over it. So metformin, which is also glucophage, it inhibits hepatic gluconeogenesis, and it's the first line medication. So metformin is also a bit is like one of the best treatments for type 2 diabetes. Okay, like you can advise this, but if you give you can advise this, which is dietary modifications, but you can also give metformin to the patient. Now sulfonylurea, they try to increase the insulin secretion, like how pancreas secretes insulin in type 2 diabetes, but not the amount that the body requires. So if you give sulfonylurea, it will increase that insulin secretion. Okay, now talking about thiazolidinones. Okay, now that decreases the insulin resistance, and this is what we want, right? We need to decrease the insulin resistance in type 2 diabetes. GLP agonist. GLP agonist was a glucagon-like peptide, and it encourages the release of insulin from the pancreas. That is, it increases the volume of the beta cells in the pancreas so that they can produce more insulin, right? So increase glucose-dependent insulin secretion. They also promote weight loss. Now, DPP4 inhibitors, like just good over it, it like increases the endogenous GLP-1, and like how I said, GLP-1 is glucagon like peptide, and it increases the number of beta cells in order to secrete more insulin. It also reduces appetite. SGL2 inhibitors, where is basically it blocks the sodium glucose co-transporter, and it increases the renal excretion of glucose. Okay, so more and more glucose that was being accumulated in your body and forming hyperglycemia, a condition called hyperglycemia. Like you can give this, and there is going to be increased renal excretion of glucose, and like glucose will be leaving your body through urine. Okay, so it will like kind of help you decrease the level of glucose. Now, complication of diabetes, premature atherosclerosis, that is including cardiovascular disease and stroke. Pretty simple. Also mentioned here, I believe. Here, cardiovascular diseases and stroke. People with type 2 diabetes are more prone towards heart diseases, and retinopathy, problem of the eyes, damage to the small blood vessels and nerves that damage the small blood vessels and nerves of the retina, causing vision problems. There is nephropathy and neuropathy, which is caused mainly by the glycation of proteins. Now, again, signs and symptoms: skin infections, arteriosclerosis, diabetic retinopathy, heart damage, permanent kidney damage, fatty liver, and osteoporosis. Now, talking about gestational diabetes, now this is the kind of diabetes that the mother would have during pregnancy. And an interesting fact is like in most of the mothers, after they have delivered the baby, they do not have diabetes anymore. But now, since the mother has gestational diabetes, what happens is the child also gets more and more glucose, right? So as a result, the child will be having a condition called fetal macrosomia, which is basically a newborn who is significantly larger than average. Okay, like the normal weight is 3.5 kilograms. So this kind of baby could be around 6 kg or 7 kg, like 5, 6, 7, like it's more than normal. So that is called fetal macrosomia. And now, how do you prevent diabetes? No preventative treatment for type 1 diabetes. Of course, diabetes is something that's chronic. Like it's going to be there through your lifetime. You cannot prevent, but you can have something that would improve your symptoms. So for type 1 diabetes, I mentioned for type 1 diabetes, you can have insulin therapy. And for type 2 diabetes, the symptoms can be improved through the combination of diet, weight loss, exercise, and the control of hypertension and dyslipidemias. Okay. All right. I think we're almost done. This is like just a summary. Pretty much mentioned everything here. Remember that in type 1 diabetes, the patient is undernourished or malnourished, and the reason for that is because there is insulin deficiency. The pancreas, it produces no insulin, almost no insulin, or very little insulin. So, and insulin is a hormone which is necessary for cells to absorb glucose from the bloodstream to use as energy, right? That is what I mentioned. Now, without enough insulin, the cells do not have access to glucose, so they will have an energy deficit. So, what happens since cells cannot use glucose effectively, the body will break down muscles and fat stores for energy. Now, that leads to weight loss. Now, because your muscles are being broken down, your fat stores are being broken down, you're unable to use glucose. So that is why the patient becomes undernourished, and obesity, like we already mentioned up there, it's like one of the main factors as to why type 2 diabetes is very common. Mentioning about the inflammatory inflammatory factors, which are interleukin 6 and the hormone adiponectin. Adiponectin is decreased, interleukin 6 causes inflammation, and both of them decrease adiponectin and interleukin 6. They would not allow insulin to work properly, right? So, this is why the patient is obese. And yeah, this is all the anti-diabetic drugs already mentioned. We didn't really have this 2 years back, as far as what I remember, but I would recommend that you guys should know the mechanism of action of metformin. Um, Whatever was mentioned about metformin up there. Yeah, just remember the others. Like I'm assuming that metformin could be asked because it's like a first line treatment when it comes to anti-diabetic drugs. And again, this is summary as well. Like you guys can go over it. I've mentioned everything, and that's it. That's pretty much it. Inshallah khair. I think your exam is on the 21st, which is about like in 5 or 6 days, and I hope it goes well. One of the advice that I would give you guys is to have a good amount of sleep, especially before biochemistry, because you will be having around 100 questions, and then you have SEQ separate. So you might feel drained by the middle of the exam, but don't give up. Like, do not give up. If you ever feel like giving up, just remember I said don't give up, and have a good night's sleep, because when you sleep well, you will have a good attention span, and you'll be able to recall things more easily. Okay. And yeah, good luck for your exams, and very happy to be doing the last sessions of both mol 1 and mol 2. If you guys have any doubts, any questions about this lecture, please feel free to text me, to email me. I'll be more than happy to help. And yeah, here's a feedback form. Do let me know how I did this semester for mol, and especially in this lecture. I'll be more than happy to take any sort of constructive criticism. And yeah, good luck. Thank you very much, Shahid, for recording this session. Yes, sure, you can ask a question.